Hi, I'm Emily and had COVID in 2020 and long COVID following this. I'm one of the PPI or Patient and Public Involvement Group on the STIMULATE-ICP study. PPI group members have been involved at all points and in all the different streams of the study, from funding bids, study design and onwards. Our feedback and insights will also be incorporated into the outputs or papers. We attend study meetings and review documents, asking questions, asking for clarification, and providing input to the experts running the study. So the aim of PPI involvement for STIMULATE and other studies is to incorporate expert opinion from real-life experiences of illness, making sure the right questions are asked and that those outcomes are relevant and helpful for patients. I've definitely felt welcome and included within the broader STIMULATE team, and in particular by Christina van der Feltz, Cornelis, and the rest of the work package 3b team. Today, I'm asking Christina questions so that we can explain this part of the study, which is part of the third work stream.
I'm a psychiatrist and epidemiologist since 1992. And my main interest is the interface of physical and psychological conditions that need specific attention in diagnosis and treatment. And I've been a consultant providing advice on that to clinicians for many years. I specialized in complex medical conditions that cause disability and distress. I do research to support clinicians in diagnosing and treating such cases, and I helped develop integrated care models for that. I worked with PPI members and conducted several expert studies following a Delphi design. So that is helpful as I conduct a Delphi study in STIMULATE to explore what integrated care models for long COVID and other long-term conditions would look like. In my research, I tend to challenge beliefs that seem not to be corroborated by data. I find that it is wrong to assume that if current diagnostic methods cannot find a cause for a condition, it should automatically be considered a psychological condition. It would be better, according to me, to admit that the symptom so far has remained unexplained. But that does not mean that there will never be an explanation. I led a James Lind Alliance group to set research priorities for such symptoms, and the steering group termed them medically not yet explained symptoms. I think that that is a good term. Psychological aspects cannot exist without a link to the body. There's no such thing as a free-floating psychological influence. So in STIMULATE, when looking for explanations, we keep all options open. We explore biological, psychological, social, and healthcare-related factors that might play a role, and we strive to find underlying mechanisms for all these factors as well as we can. And this will help us to develop effective treatments and healthcare provisions. Since the start of the pandemic, long COVID clinics have been set up in the UK, providing integrated care. The aim of Work Package 3b is to explore how such integrated care could be made transferable to other long-term conditions, like COPD, cardiac conditions, diabetes, but also medically not yet explained symptoms, depression, anxiety, and brain fog. In STIMULATE, the Delphi process is a way to involve experts in putting together recommendations about integrated care for long COVID and for other long-term conditions. The experts are patients and clinicians involved in long COVID and in other long-term conditions. They help with the development of the surveys that are run in the public and in clinicians, and they help with the interpretation of the results of the surveys. They will also help to develop recommendations for policies to improve treatment for long COVID and other long-term conditions. The The questions were put together based upon the research protocol that had been developed with the whole STIMULATE team, with PPI input and input from the expert panel. The first round of the Delphi survey asked open questions, as it aimed to gather as much information about the topic as possible in order to not miss any relevant information. We explored the current treatment provision in several healthcare settings, and we asked participants what integrated care should look like. We did that in long COVID patients with a wide range of symptoms, in long COVID clinicians in a range of healthcare settings, and in patients and clinicians regarding a variety of long-term conditions. We combine all the material from the surveys to develop statements about what integrated care should look like. We show these statements and the input from the surveys that they were based on to the expert panel, and we ask them if they think the statements cover that material well. This produces a list of statements to be ranked by the public and clinicians in a second survey, and we then calculate the level of consensus regarding those statements. The statements ranked the highest in terms of priority and consensus are presented to the expert panel, and that panel then confirms the first 10 to 20 priorities and describes policy recommendations based on those. All statements should be the result of the material from the first survey. The expert panel cannot invent new statements or change the ranking that was provided by the public and clinicians. We follow this process in a transparent way, much as is done in the method of the James Lind Alliance, to be sure that the final recommendations are based upon input of independent patients and clinicians.
So the whole process ends up taking consensus from patients and clinicians about what good care looks like and coming up with a set of statements for policy recommendations.
That is right. We know that the long COVID clinics that are currently being set up all over the country vary a lot in structure. And by this research, we may be able to indicate certain requirements that all clinics should preferably meet. Some integrated care pathways for long-term conditions are already well organized and properly funded. However, this is not the case in other ones, and especially for those, we hope that we can provide a common structure that would be beneficial. I think that this study will provide much needed input to policymakers and hopefully will lead to further or better funding of long COVID clinics and integrated care pathways for other long-term conditions. Good thing is that this will be directly fed and informed by patient and clinician input by the Delphi method. And I anticipate that this way our recommendations will be taken quite seriously.
Well, I certainly hope so, and I look forward to that. Thank you very much for joining me today and for sharing all your expertise and insights. And yeah, it's been a pleasure to discuss work package 3B with you.
Thank you, Emily, and likewise.